My name is Jens Chapman, and I hope all of you had a reasonable Valentine's Day. It's to be commended that you sacrificed probably time away from your loved ones to come to gloomy, rainy, blustery Seattle. So thank you for that. And I'm going to try to advance the slide. Lee, Alexis, oh, here we go. So yes, you're at a lateral course, but yes, I'm talking about posterior exposure. By the way, CNN recently recognized us as the most gloomy city in America. So I hope that the bright lights and the bright minds of the Seattle Science Foundation here will give you some inspiration. So I realize that we're at a lateral access course, and I want to congratulate the course chairs and these artists, visionaries that are here, Dr. Hines, Dr. obviously Uribe, Oscuyan, Park, Meneses, all of these wonderful colleagues. They have really contributed greatly to the expansion of spine care. And one of the very key things that you've heard, aside from neural decompression and treating the patients, is the restoration of sagittal balance and the fight towards getting that through a meaningful anterior column reconstruction that is as atraumatic as possible is a really big deal. And the spine as a motion unit should be considered as an organ, as it's interactive in all its dimensions. And again, how we can kind of restore these atraumatically, if need be, is really important. Now, we're obviously in an era of acronym salad, and again, it's kind of confusing how many different words and things keep coming up. I apologize for any misspellings that there may have been at the flash forwards. In terms of the CME declaration, I do not have any conflicts of interest. I do want to point out that this talk is meant to be discursive and dialectic in a Hegelian fashion. So I'm really pointing out that no excerpts of this talk are to be used out of context. Thank you. And again, I do consider myself not a technophobe. I'm not anti-development in any way, shape, or form. I also don't like to radiate everybody around me, and I love my patients, my family. And I'm really not against these far lateral exposures, absolutely not. But I do like this quote by Sigmund Freud. I think the voice of reason should stay here, and this is what this talk is about. Maintain a voice of reason in terms of what we can do with the posterior exposure. So I'll try to review some of the basic concepts and also show some of our more recent research in terms of what can be done for posterior deformity corrections, because as Professor Uribe pointed out, the standard dogma, and this is what this talk is really about, is not straightforward. So I do also think that as our society is aging and it's getting more and more sick, they are presenting us with unprecedented challenges. And again, having a continued evolution of our technologies and our treatment options is a really big deal for us. I also am very unabashedly pro-spine surgery. I do think without a question that we can positively change lives, and I can't even imagine how this 14th century woman in Venlo, Holland existed for her life. She was said to be about mid-50s. So the spine, we now recognize through all of our various outcome studies, is truly a nidus for a significant burden of disease. I call it the gestalt of the spine. And again, as we age, the profile of our spine really changes and falls forward. So this is one of those fundamental recognitions that's, I'm sure, well aware to all of you. But this is, again, one of those things that fascinates me and terrorizes me, that we're all kind of fighting, hopefully not as surgeons, but also as being circumspect spine physicians who can educate our patients in a far more than pure surgical consultative fashion. So this is my pitch. This is not a place for dogma. This is not a place to have just one approach for everything, and this is one thing that fulfills me with concerns. For instance, for pelvic fixation, the mantra now somehow has become S2AI screws, right? I mean, this is what's taught everywhere. Wrong. Iliac screws have a lot of very substantial advantages, and again, that's kind of just fallen out of fashion. The same thing I now see for our absolutely creative and very cool new anterior and lateral procedures, because they're very novel. They require a lot of attention to detail and artistry, but at the same time, it's suddenly turned into a dogma. This is what you have to do. And again, I want to remind everybody that the great Professor Dubussé is the godfather of the cone of efficiency, which we're trying to restore. So the path there is multifocal. And the angles, again, is a great example of the dogma that we all are underlying now, is very important to understand. But again, then creating a rigid perspective as to how this should be treated is a problem, because every patient is different. We have to have a far more balanced and circumspect appreciation of patients. And there is no question that 2 of these 3 procedures that are recommended in the dogma section of the spine deformity world are pretty traumatic surgeries, right? I mean, they are substantial. So my pitch to you is in this talk to consider the posterior parts, and we'll introduce you to the so-called intradiscal osteotomy in a lab. As I'm going to switch to the lab, Juan and maybe some of our course chairs can take the podium here because I'll get changed. Juan, is that okay? So after the talk, I'll interact with you from the dressing room whilst I get changed. So the question is, what if and how can we do this? And again, posterior approaches have somehow become uncool because we're worried about the muscle trauma that we do. But at the same time, we do have a bilateral exposure to the neural structures, to the joints. It's multi-segmental. You don't have to worry about angles, pelvic crest, etc. And yes, you can restore the spinal column tension band in the front. So being clever about how we expose muscles, how we don't kill the muscles with retraction, how we do postoperative pain management and closures, how long we retract is the same story as is for the XLIF surgeons who try to do their monosegmental fixations within a half an hour. So we have to be far smarter how we handle our muscles. If we do that, we can avoid having to go from the front of the spine, where we'll learn from our general surgeon that there are a couple of structures around there that really are a problem. And as you're looking at these less invasive surgeries, I can tell you from a risk management standpoint that, again, in the hands of artists, these work beautifully. And usually they go very well in the hands of most surgeons. But if there is a problem, the problem can be very fulminant and very brutal. And again, our course participant, what was your name? Ahmad asked a great question. That is, if you get a vascular injury, if you get a ureter injury, if you get a colon injury, that small kind of a procedure that you did very elegantly can really disproportionately go into disaster very rapidly. So this is not just a trivial deal to deal with this. And that also goes to the diaphragm and how we handle that, and again, the sympathetic plexus and the various roots. If we look at the literature, this is still not very good in terms of comparison and compare lateral procedures to posterior procedures. There's relative equipoise, and again, there's a strong suggestion that there's a examiner bias, but the far lateral procedures, in all honesty, in the published literature, don't look so bad. The clinical reality is that probably 1 in 5 patients have a significant plexopathy for a while, at least for 3 months, in the far lateral exposures. Again, level and surgeon dependent. And we always have to tell patients that these patients routinely will have hip flexion and knee extension weakness at least for a couple of weeks. So where's the state of current posterior thoracolumbar surgery? Now here I have a question for all of you. One of the epitomes of beauty, of female beauty, is the statue of Venus. And she was at the time apparently 19. She was healthy. And if she wanted corrective surgery, would you do a posterior midline surgery for her adolescent idiopathic scoliosis? Yes, she is the poster child of AIS. It's been, all the things point to that, and she has a classic compensatory posture. So would you do a single posterior midline incision if this was your daughter, or would you start hitting her from the side with a variety of XLIF procedures, or maybe pock marker backside? One.
What is the bone density?
I rest my case. So again, yeah, you have to take the arms off to get far lateral, right? So the expanded axis that Dr. Uribe doesn't talk about. But no, seriously, I mean, this is, again, one of the things you can obviously choose many pathways towards the spine, but in the adolescent idiopathic scoliosis community, a posterior midline exposure remains the norm and allows for very powerful corrections. So again, the question is now, how does that translate into adult deformity surgery? And again, it's technically feasible in the hands of artists like Dr. Park and many colleagues. I do have to acknowledge, and again, I want to pick up to what Juan said, PSOs are a very bloody procedure, even the best of hands. I mean, this resection right along the segmental arteries and the veins and the cancellous bleeding bone surface is in the best of hands and a very expedient, well-controlled surgeon and about 500 cc's blood loss. It can be far worse than that. So a PSO is something that we, and in my practice, very rarely use anymore. And I'm very apprehensive when young surgeons tell me, oh, I'll do 2 or 3 PSOs there. That's where problems happen. So I do think that we're in an era where PSOs should should probably be far rarer, and this is where I kind of want to acknowledge the great impact of our surgeons. The other thing is if we shorten the neural column, which I think was always underappreciated, we do create problems such as arachnoiditis that I've seen in multiple patients with PSOs delayed. So this is something that, again...
Even without
Pardon?
Even without the dural tear?
Without a dural tear, yes. It's just dural buckling that basically inflows and changes the flow characteristics of the sac. I don't know the reason. I mean, these are patients that I've seen. I can't give you a statistic or anything like that, but it's something that has led me towards getting CT myelograms in post-PSO patients who have problems on a delayed fashion. I'm talking about years later frequently. So conventional surgery probably needs a remake, and again, this is something where I think that the common kind of prejudice almost against conventional open posterior surgery really needs to be overhauled. So what I really need is somebody who is enigmatic, like Dr. Oskuyan, who can be a spokesperson, have a new name, and put down the rivals so that posterior surgery suddenly becomes better. My suggestion is that we have a new name for it, and we call it the Atergo approach. The Latin term of this is from behind. It can also be called the Tiger approach. And again, this is something where we really can think about how we elevate the muscles better, how we retract better, and rebalance the spine and do all the things we want to do from the back without shortening the neural column and having a less bloody procedure and a hopefully reasonable length of stay and blood loss altogether. What I'm seeing in my clinical practice now far more are these Uzi type approach patients. I mean, they've been riddled with incisions left and right. And this is actually a conservative example. I have a more recent couple of patients who I think would have even served as a more impressive thing. I don't know that this is an advancement of spine surgery when I see this. And again, it depends upon the patient, obviously. But this is something that I hope will provide all of you with food for thought as to what we're doing. And a single midline incision with a more comprehensive approach may be a better approach than this kind of a surgery. So muscles have to stay viable, as innervated as possible, realizing that with a conventional open procedure, we probably sacrifice the semi-spinalis to some degree, and certainly the multifidi, but we can achieve a full neural decompression and have a realignment of the spine. So physiologic retraction, less myonecrosis, better wound management are some of the things. And again, this is my main pitch, and this is what I'm going to show in the lab. We've learned this from spondylolisthesis surgery, such as in this patient with a grade 2 spondy at the bottom and kyphosis. We can do sacral dome osteotomies and fully release the spine and then achieve a very meaningful lordotic physiologic realignment. Again, very safe for the L5 roots. This can all be done from the back. Could it be done from the front? Of course. Could it be done from the front and the back? Of course. But this is with a single, about 5-finger breadth incision with a very safe, comprehensive release, decompression, and predictable fusion. These are just some snapshots how this kind of a posterior intradiscal osteotomy translated to other segments of the spine can work. Full pedicle to pedicle resection, a little decompression above and below. We'll show it in the lab. Fixation at the target level, at least one level, but it can be more if needed. And then release of the disc from the back. And again, then carefully spreading the vertebra apart. Again, we'll show you that in the lab. This is how this looks in deformity surgery. And again, you can achieve literally at any level of the spine, all the way up to the T1 level, without any retraction of the main neural tube. A very comprehensive decompression by doing this from both sides and doing literally a pedicle to pedicle, a release and distraction and restoration. So this is all possible, and again, modern implants and safe, effective distraction and manipulation techniques under fluoroscopy can achieve this kind of a release, hardware placement or graft placement, and then realignment to achieve a comprehensive realignment. I want to just feature some of our wonderful fellows, and they've done clinical and biomechanics work. I'm not going to show the latter, but in a clinical comparison, they basically looked at intradiscal osteotomy techniques with a variety of cages. This is again just a little schematic graph, and this is basically a principles picture, and again the main neural tube with its cord or cauda never has to be retracted. And again, this is an unreadable slide, but assume that in terms of comparing static and expandable cages, we saw no demographic changes. The number of patients is modest, but this is, again, a clientele with about 2 years follow-up. We also have, as the light gray barrier, XLIF patients in there. I'm going to try to show this and highlight this. So the blues in this shaded form are patients with a static cage. Then the light gray one right next to that are the expandable ones. Then we have X lifts, and you'll see no X lifts at the L5S1 level. How does this translate into deformity parameters? Again, this is an unreadable slide, but the general deformity parameters that these patients presented with showed no differences, but the change in terms of height restoration was by far highest with expandable cages with an IDO far over X lifts. Now again, there are different clinical demands I'm going to submit, but this is a about 50-strong cohort with 2 years follow-up. And again, these expandable cages plus an intradiscal osteotomy are a very powerful way to make a deformity correction happen. And if you look at complications, they're literally identical between the two groups. So this is a case in question. And again, this is one of those frustrations of our life. We've done a long fusion. The patient did quite well from that. The patient developed a proximal junctional failure. And again, she received an intradiscal osteotomy, and she's given me permission to show this. She has a full balance as she balances across the Sydney Harbor with a fully fused spine. So the Atergo philosophy basically is, again, something that I hope that we can kind of include. My suggestion to get rid of this acronym salad that I briefly showed in the beginning is to summarize them under the Latin term ex parte. That's a Latin term for coming out of nowhere from the side. So this is my suggestion to kind of contrast the al tigre or posterior approach. My personal also thought is that over time we'll have to look at cost efficiency, and this is going to be a very interesting comparison because these anterior procedures, as elegant as they undoubtedly can be if everything goes right, can be very efficient, but they're also very expensive per level. We think about $8,000 per level is pretty easy or more, neuromonitoring and everything aside. And the outcomes, again, we still don't know how they work if we have more comprehensive deformity patients. So the conventional posterior procedures are powerful. They do allow for a very comprehensive kind of a restoration of sagittal balance. But again, the question is how those two compare. So if we do an if or an and or, I would really suggest that when we have these modern-day disasters like the 67-year-old patient who looks truly like a modern-day reincarnation of this lady from the 15th century Holland, with a multitude of previous spine surgeries, is probably best treated with, drumroll, a combination of both. Again, this is CT myelogram, and here Dr. Oskuyan did 2 levels of X lifts, and I did a intradiscal osteotomy on top of that, and we got a pretty reasonable, I would say not perfect restoration. The patient, I'm happy to say, is actually thrilled with this. So again, we have multiple platforms now, and this is cool. This is amazing, and we have so many different things that we have to contend with nowadays beyond just the degenerative perspective. Infections, trauma, tumors, deformities. The spine is an organ system that is not recognized as such. It should be, but we also are blessed now to have far more platforms to try to deal with all these various challenges. So in terms of Atergo versus ex parte approaches, I would really say, let's go back to the back and keep that in mind as a powerful resource in our armamentarium. With that, I close. Thank you. Maybe I'll take one question or comment or criticism, and then I'll run off to get changed into the lab and see whether I can replicate what I just talked about in vivo, or in cadavero, I should say.
Questions for Dr. Chapman? Great talk. I've got a question for you, Dr. Chapman. We know that posterior reconstruction is the base of spine surgery, and 70% of the surgeons around, 80% around the world, is still doing posterior-based approaches. My question is, how often you see in your practice here in U.S. Flat back surgeries for degenerative simple, single or two-level cases done by posterior approach? And what's your opinion about that? Because, I mean, when we spread around the world for posterior-based surgeons, we still see a lot of iatrogenic flat backs. What are your opinion about this?
So there are multiple tangents to this. First of all, I think any fusion surgery is a deformity surgery. And it's under-recognized and untreated as that. I mean, when we do a posterior surgery and any fusion or an anterior neck fusion, restoration of something that is commensurate with the sagittal balance of the patient, reflective of their general health, connective tissue disease, muscle strength, etc., is crucial, under-recognized. So that's my latter answer. The prior part is a really interesting one. When should we use anterior, posterior, and when can we just go posterior or just go anteriorly? I again think the balance is important, but I'm going to ask a question to the audience here. Hopefully none of you have this, but I ask everyone in the room to answer this. If this was you, ortho, neurosurgery, general surgery, I don't care. If you have a single level degenerative grade 1 spondy that's unstable, you have a high-grade stenosis, you failed everything because you don't want to have spine surgery, okay? You know everything, you've seen a lot, you don't want spine surgery, but it's not working. What would your choice of treatment be? Would you allow a surgeon who you trust to do a posterior-only surgery? Show of hands, please. Okay. Would you trust, Dr. Park, what was your hand doing? It was kind of going up and then down.
Oh, I was going to say,
You waved me off. It was something in between. Would you go, Dr. Park, and then all others, anterior only? Would you cut open your precious, previously unviolated abdomen by an expert surgeon? Would you go anteriorly only? Show of hands. 2 brave souls. Who would want to have an anterior and posterior surgery? A little bit more. It's almost equipoise. So I don't know what your interpretation of the numbers was. I think this is very reflective. I think a small majority may have voted in favor of posterior only. A fair number of patients voted for anterior and posterior. Hardly anybody, except for 2 brave souls, voted for anterior only. Now I'm going to change the perspective. You've had your 4-5 fusion, however you wanted it done, okay? And you're coming back 3-4 adjacent segment disease way earlier than what anybody wanted. And you've had an anterior surgery done. You were in that collective of the about 40% responders who want to have an anterior posterior surgery. Would you go back, same question, and have another anterior surgery done? Show of hands. You've had a previous anterior surgery, very few. Who would want to go posteriorly only? Dr. Park, you're again using that hand motion. He needs a microphone, though. We can't put this on record unless he has a microphone.
Here.
He needs to be on the record. It's very confusing for me because he has these hand motions that go up and down.
Yeah, no, so I was waiting for you to finish talking. I didn't want to
I'm sorry, I'm too loquacious.
But my point is, like, I'm a neurosurgeon by training, obviously, and when I went through training, neurosurgeons did not believe in indirect decompression. In fact, we were actively cautioned against indirect decompression, that it didn't work. And over the years, I've come around. You know, I like indirect decompression. I think it works very well. And in some ways, I think it violates less tissue. You know, any type of surgery destroys surrounding tissues. This is how we get our exposure, right? But if you could do a small sort of muscle splitting anterior approach, say with the lateral that we're all very comfortable with, I think you don't do much except impact the disc space. You know, the posterior elements are all intact, and indirect decompression does work in many cases. So you're violating the least amount of tissue to get your job done, I think. And so I think it's a viable option. So as to your question about what would happen if you had adjacent segment disease after an anterior approach, I've had that situation occur, and you could just go on a contralateral side and still have virgin tissue for the most part, I think, depending on what level you're at, and do the same operation and get a pretty good result. So I think when it comes to surgery, there are a lot of different ways to treat a problem, and to a certain extent, it is what you're comfortable with as a surgeon, what you feel will get your best outcome. So in a lot of cases, there's no right or wrong answer, right? I think it's, there are a lot of factors involved. So that's why I hesitate a little, because I think a posterior approach will work in a lot of cases. Anterior approach, to a certain extent, what you are comfortable as a surgeon.
So I think we can agree that there are many pathways and there are many different variables that we're not talking about. How flexible is the spine? What kind of facet disease is it? Are they loose facets, or are they just hypertrophic, large, ugly facets, osteoporosis, etc.? My main point in the last scenario was, if you've had a previous anterolateral surgery, a revisit, and maybe we can ask our general surgery colleague also, Jill, a revisit into that same space becomes a very different proposition, even if you had the most atraumatic, small first approach, right? I mean, for you, if you have a phone call from your friendly spine surgeon, hey, I have a redo anterior exposure, your threat level probably changes a bit, right?
Your first thought is, oh no. Oh no, not one of those.
And it doesn't matter if it was a wide open exposure or a tissue sparing ex parte lateral exposure, right?
It's the fact that the retroperitoneum has been operated on, and you have created an inflammatory process, and you're going to have to deal with that if you go back in, no matter what.
So again, am I right or not? I mean, you require a lot more circumspection than, for instance, than looking at the ureters or things like that, especially if you stay pre-psoas,
Yes.
than the first time. So stenting, et cetera, looking for a ureter, dissecting around, not even thinking about the vessels becomes a far bigger issue, right?
Yes, and I mean, thankfully, you have two sides. So if the left side was the initial approach side, you can consider going to the right. It also depends what level you're going to. And nowadays, sometimes I say, thank God for X-lifts, because that's really helped us out a lot.
Yeah, just contribute with this discussion. I mean, I totally agree with you when we perform, for example, an A-lift, especially for 4-5, that you will be in trouble to get back by anterior approach. But after doing an X-lift, for example, for 4-5 or the O-lift for 4-5, and you need to go to 3-4 for adjacent segment disease, you have the contralateral side, as Paul said, but I had many situations that I had to go back on the same side, and no problem at all because the section is so small, and you can create the safe corridor as well. So it's not a big issue about this. And another point, not in your hands that I know that manage this so well, but how many of you have in your practice posterior basal L4 to S1 cases with adjacent segment disease on 3-4? Is it something very rare in your practice or very often, especially in patients with high pelvic incidence? This is the key point. I had my main problems with posterior basal approaches when I started trying to push myself to put larger cages anterior to get and to restore more lordosis and to do wider osteotomies. What do you think about that? Because, again, in good hands, in Paul's hands, in Uribe's hands, the lateral will work very nicely. In Dr. Hines' hands, the O-lift will work perfectly. In your hands, posterior basal will be perfect as well. But, I mean, generally, talking about all the world and spine surgeons around, how often you guys see a 3-level lordotic disc space trying to compensate a flat back from a posterior basal L4 to S1? Any comments?
I'll give you one comment immediately, then I'm going to ask to be excused to
Sure.
get changed. I'm going to tell you the rate of adjacent segment disease is 100%, regardless of what surgery you do next to any form of fusion anywhere in the spine. You just have to look long enough and hard enough, and you'll find 100%. And it really, in my experience, doesn't matter whether you used more or less invasive. Certainly, we can propagate it with any form of violation of adjacent soft tissues and things like that, no question. And the propensity towards posterior procedures, violating other facet joints, destabilizing the spine by injudicious resection of the PLC, et cetera, is probably higher. But in the big picture, it's the same problem all over, and just restoring the lordosis, which we all want to do,
do you agree that
is
the
not
key
a factor.
point for us to discuss here is to keep alignment?
That was my first thing, the lady from Holland. We need to try to reverse aging, reverse the natural instinct to fall forwards, and restore a physiologically balanced spine, which is our common goal. With this, I'm going to excuse myself, and we can continue the discussion.
Sure,
Possibly,
and
maybe you can
I will
keep
try
talking.
to moderate you on the video, okay?
Thank you all.